Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Dr. Muhammad Zakwan bin Yahya. Okay, currently third year radiology trainee in HUKM. Okay, working as a trainee lecturer at Kuliah of Medicine, IIM Kuantan, and one of the I-Medik activists. Okay, today I will share with you chest radiograph. Okay, how to approach a chest radiograph. As we know, chest radiograph is one of the commonest radiology or imaging requests in any hospital. Okay, so as a medical officer, as a house officer, even or as a medical student, okay, we will come across a chest radiograph at least once a week, twice a week, okay, or every day even. So it is important to know how to approach a chest radiograph. Okay, this is my outline. Okay, the basic okay, regarding the chest radiograph. Okay, the first one is the correct patient, and then the image quality of the chest radiograph, and I will talk about a little bit on anatomy of the chest radiograph. Later on, the systematic approach into a chest radiograph. Okay, for the first one, we have to make sure we have a correct patient. Okay, we need to check the patient's detail. Okay, patient's ID, name, date of birth, the date acquired, and then time acquired. So it is important for us not to just simply look at the chest radiograph without knowing that we have a correct film for the correct patient. So because if we interpret wrongly, I mean for the wrong patient, so the management to the real patient will be different. So it is important at the first place we get a film, we have to make sure we look at the correct patient. Okay, and then the second one, the quality of the X-ray. So or the chest radiograph. Okay, RIPE. For the first one, rotation. Second one, inspiration. Third one, penetration, and lastly, the exposure. Okay, for the R, for the rotation, the rule of thumb. So medial end of each clavicle must be equidistant from the spinous process or center of the spine. Okay, spinous process at the vertical and central. And then we look at the medial end of the distance from the medial end of each clavicle. Okay, what is the disadvantages of the rotated radiograph? Okay, the first one, if the film or the patient rotated to the right, the manubrium, superior vena cava, SVC, or the vessel of aorta will become unusually prominent. It will simulate mediastinal mass. Okay, if the patient rotated to the left, so the aortic arch will appear enlarged, and then either way of the rotation, one lung will appear blacker than the others. Okay, this is example of the rotated radiograph of on the right hand side, on the left hand side B. So the patient is rotated to the right, so the SVC, superior vena cava, appear enlarged, appear prominent, and then on the right hand side C, the patient is rotated to the left, so we can see the aortic arch is appear enlarged. Okay, the second one, I, inspiration. So the rule of thumb, so we have to see at least 6 anterior ribs live above the left dome of diaphragm. Okay, what is the importance to have a good inspiratory effort? Because a shallow inspiration, shallow or under inspiratory radiograph, so we can see there will be crowding of vessel. It will simulate lung infection or subsegmental collapse, and the side-to-side diameter of the heart will appear enlarged. So we can see here, okay, on the left hand side A, we can see 7 anterior ribs, okay, above the 6 anterior rib above the left hemidiaphragm. On the right hand side, under inspiratory film, we can see only 5 anterior ribs above the left hemidiaphragm. Okay, and then the third quality, I mean for the P, projection. So we have to make sure whether we look at the AP or PA, anterior posterior or posterior anterior projection. What is the importance? Okay, we prefer the posterior inferior projection because there will be less magnification. The heart, the mediastinal, and all the structures will be less magnified. Okay, and the other all these are the differences between the PA and AP projection. We can see the clavicle will be more vertical. Okay, the ribs in the PA will be prominent anterior rib, and so on. So the advantages of the PA radiograph, so patient will be the image will be taken in a standing position, so it will allow full lung expansion, and it will prevent engorgement of the pulmonary vessel, and we can see the visualization of the air fluid level. For what is the advantages of the AP radiograph? There will be mediastinal magnification, so there will be false impression of cardiac, mediastinal, or aortic enlargement. Okay, because the patient also taken in the either supine or sitting position, then will be the patient will be unable to take full inspiration, so there will be crowding of vessel. It will simulate lung infection or subsegmental collapse, and the side to side diameter of the heart will appear enlarged. Okay, the last one, exposure. So the exposure, we have to see the at least we can see spine behind the heart. Okay, the spine is visible behind the heart. Okay, you look here. Okay, as a summary for the quality. Okay, for the R, we can see the middle end of the each clavicle equidistant with the spinous process. Okay, for the inspiration, we can see the 6 anterior rib above the hemidiaphragm, and then the projection, either PA or AP projection, and lastly the exposure, we have to need the have adequate exposure. We can see the spine behind the heart. Okay, now I will talk a little bit on anatomy of the chest radiograph. Okay, the first one, this is the trachea. Okay, number 2, hilum bilaterally. Okay, number 3, lung fields. We can see we need to assess. Later I will talk about more detail on regarding the lung fields. Okay, number 4, the hemidiaphragm, right and left. Okay, number 6, okay, we can see the aortic knuckle representing the aortic arch. Okay, number 7, ribs bilaterally. We have to see the any bone abnormality or bone fractures. Okay, any normal variant and anything, we have to see it. And then the scapulae bilaterally. Number 9, breast shadow or soft tissue shadow. And then lastly, the bowel gas. Okay. Again, the anatomy. So this is the mediastinal outlining of the mediastinum. From craniocaudally on the right side, okay, there will be great vessel or right paratracheal stripe, and then there will be arch of a zygous vein. Okay, below it there will be superior vena cava, and then followed by right atrium forming in the right heart border, and inferiorly, the most inferior is the inferior vena cava. On the left hand side, there will be left paratracheal stripe followed by aortic arch, okay, and then aortopulmonary window, and then we can see the main pulmonary artery. Here is the main pulmonary artery, and then the left atrial appendages or auricle of the left atrium, and lastly the left ventricle forming the left heart border, and the pericardial fat pad inferiorly. Okay. Then regarding the anatomy, we will be dividing the lung field into upper zone, middle zone, and lower zone. Okay, later I will talk about the apical lung apices. Okay. Okay, we take the upper zone from the 2nd to 4th rib, and then the middle zone 4th to 6th rib, and below the 6th rib there will be so we will call it lower zone. Okay, now we go to the systematic approach of the chest radiograph. Okay, with the mnemonic A, B, C, D, E, F, G, H. For the first one, we need to assess the trachea. Okay, the trachea need to be central. Okay, and then we see any tracheal deviation, either it is pulled or pushed to the same side or the opposite side. Okay, case number 1. We can see here, this is frontal chest radiograph. Okay, there is a right lung collapse with a tracheal deviation to the right side. The trachea is being pulled to the right side, to the same side of the lung pathology. Okay, the second and third case. Okay, on the left hand side, this is a frontal chest radiograph showing massive right lung pneumothorax causing the mediastinal shift and tracheal deviation to the opposite side. So the trachea is being pushed to the opposite side of the lung pathology, which is the right tension pneumothorax. Okay, on the right hand side. Okay, then the third case, we can see there is a massive right lung pleural effusion with a tracheal deviation to the opposite side, and then the trachea is being pushed from the side of the pathology, lung pathology, which is on the right side. Okay, for the breathing, okay, these are the lung lobes. Okay, we have 3 lung lobes on the right side and 2 lobes on the left side. Okay, we have right upper lobe, right middle lobe, and right lower lobe. And on the left side, we have left upper lobe and left lower lobe. Okay, it is sometimes difficult to localize the lesion or the lung pathology on frontal, on the AP radiograph, PA radiograph itself. So sometimes we need to correlate with complementary lateral chest radiograph. Now we can see the right upper lobe forming the upper part of the chest radiograph, and the right middle and right lower lobe, okay, forming most of the lower part of the lower zones of the middle and lower zones of the chest radiograph. So the right middle lobe and right lower lobe is being projected together in the case in frontal chest radiograph. Okay, this is left lobes. We have left upper lobe and left lower lobe. Okay, sometimes the lesion at the anterior part of the left upper lobe, and anterior segment of the left upper lobe, and then also it will be projected on the left lower lobe. So we can only localize it on lateral chest radiograph. Okay. Okay, for the breathing, okay, as I said previously, we divided the lung into 3 zones, and then now I will talk about the apical plus the apical. So we have 4 zones on each side. We have apical, lung apex, upper zone, mid zone, and lower zone. Okay, we have a review area or hidden area. Okay, number 1 is the I will talk about a few hidden area. Okay, the first one is the lung apices. Okay, this is a case of frontal chest radiograph. Okay, we can see the lung is a little bit hyperinflated. The lung fields are clear, no obvious lesion. But if we scrutinize on the apical side, on the right side, we can see there is a thin apical pneumothorax. So it is important to scrutinize the review area, especially at the apex. Okay, you can see here the thin right apical pneumothorax. Okay, next one, frontal chest radiograph showing the opacity at the right middle zone, obscuring the right heart border. Okay, from this frontal chest radiograph alone, the location, we can say most likely it may represent right middle zone consolidation. But how do we confirm it? Okay, we can confirm it with lateral chest radiograph. So this is on the frontal chest radiograph, we see right middle zone opacities with effacement of the right heart border, and on lateral radiograph, we confirm that it is a right middle lobe pneumonia. Okay, for the C, cardiac. So we need to assess the heart size. Okay, size of the heart. We need to take the cardiothoracic ratio, the widest diameter of the heart, and then widest diameter of the thorax, and then the ratio of it must be less than 50%, but sometimes we take 52% in Asian population. Okay, the second review area is the retrocardiac. Retrocardiac region, which is posterior to the heart. Okay, because posterior to the heart, we still have lung field. We still have lung. So the heart only occupied the anterior mediastinal. So posterior to the heart, there are still a lot of lung field. So any lesion posterior to the heart retrocardiac region, we might miss it if we don't scrutinize it properly. Okay, this is a case of case number 6. Okay, this is a frontal chest radiograph of skeletally mature adult. We can see there are the heart size is enlarged. There are bilateral interstitial opacities. Okay, with prominent vascular marking. Okay, with the upper lobe venous diversion, venous congestion, with right effusion. Okay, this is a case of this is a case of cardiogenic pulmonary edema. Okay, we look at the heart, and then we look at the lung field or the lung changes most likely represent cardiogenic pulmonary edema. Okay, next case is this is a frontal chest radiograph. Okay, if we see on the right side, the lung field are clear. Left upper zone clear, left middle zone clear. But the retrocardiac region here, we couldn't see the vascular marking clearly. So there is opacities at the retrocardiac region. Also, we couldn't outline the left hemidiaphragm. So the opacities obscuring the left hemidiaphragm, and as well as the blunting of the left costophrenic angle. Okay, so this is a case of retrocardiac pneumonia with left pleural effusion. Okay, remember the hidden area number 2, retrocardiac region. Okay, now we look at the diaphragm. D for diaphragm. Okay, the right hemidiaphragm is normally slightly higher than the left side, but not more than 3 cm. Okay, diaphragm also the review area, the region at the both retrodiaphragmatic areas. The lung marking should be visible on both sides. Okay, bilateral retrodiaphragmatic area, and both costophrenic angles should be sharp or clear. Okay, case number 8, frontal chest radiograph showing right apical mass, lung mass, and then we can see with the elevated right hemidiaphragm. So this is a case of a case of lung metastasis. Okay, right apical mass with phrenic nerve palsy from the colon CA. If we don't have any history of the colon CA, we can see apical mass or pancreas with phrenic nerve palsy. Okay, case number 9, frontal chest radiograph. Okay, we can see there is retrocardiac opacities obscuring the left hemidiaphragm. Okay, same like previous case. It is a case of left lower consolidation. My point is we need to outline the both hemidiaphragm clearly. If we don't see it, so there must be any abnormality there. There must be something. There must be either consolidation or any lesion there. Okay, the obstruction of the left hemidiaphragm with retrocardiac opacities. Okay, case number 10, still looking at the diaphragm. So what's the abnormal here? We can see the loosened line just below the bilateral hemidiaphragm. So it is air under diaphragm. Okay, we can see the lung fields are clear, but we have here is air under diaphragm. So it is sign of pneumoperitoneum. Okay, yes, it is a abdominal pathology or any peritoneal pathology, but we don't just look at the lung fields only. We need to see all the structures within these images, including the diaphragm and also as well as the below diaphragm. Okay, we can see here air under diaphragm. So it is a sign of pneumoperitoneum. Okay, and then E, extrathoracic soft tissue. Okay, look at the bone, look for any fractures or any suspicious bone lesion. Okay, as well as we need to look at the soft tissue, any swelling, any subcutaneous emphysema or foreign bodies in case of trauma. Okay, case number 11. So we can see we outline every single rib here. Okay, the first, second, third, fourth, fifth, sixth. Okay, there is cortical deformity. There is a break here. There is a fracture. 6, 7, 8. Okay, there is a left 6 to 8 posterior rib fracture here. Okay, we need to assess the extrathoracic structures like bone or soft tissue. Okay. Next one, frontal chest radiograph showing extensive subcutaneous emphysema. Look at the soft tissue outside the lung region, extrathoracic region. We need to look at the soft tissue. This is an example of an extensive subcutaneous emphysema. Okay, the lung fields I already explained in detail in the breathing. Okay, and then grab vessel, I will talk about later in the hila and mediastinum. Okay, for the mediastinum, for the hila. Okay, the hila here, it is made up of ascending pulmonary vein and pulmonary artery, descending pulmonary artery. So the pulmonary vein forming the superior part of the hilum, and the pulmonary artery forming the inferior part of the hilar. Okay, so the fourth review area is both hilar region. Okay, the left hilum should be higher than the right side, or at least at the same level. Okay, it should not be lower than the right side. Okay, look for any enlarged nodes or abnormal vessel. Okay, for the mediastinal control, the diameter of the mediastinum. Okay, the upper limit is 6 cm in a PA radiograph and 8 cm in AP radiograph. So if the diameter exceeding this number, so we can say there is mediastinal widening. Okay, this is another outlining of the mediastinum. Superiorly aortic knuckle, and then you can see here the left main bronchus, and then the descending aorta. Okay, we can look at great vessel here. On the right side is the ascending aorta forming the aortic arch, and then the aortic knuckle here is the aortic arch, and then we can see here the left main pulmonary artery. The region between the pulmonary artery and the aortic arch is we call it aortopulmonary window. This region should be empty, should be clear. Okay, if there is some opacities or lesion here, it is abnormal, and then inferior to that, so this is the descending aorta. Okay, right paratracheal stripe, and then a zygous vein here. Okay, case number 13. This is frontal radiograph with bilateral enlarged hilar nodes. Okay, this is a case of sarcoidosis. You can see enlarged bilateral hilar nodes. Okay, the next one, frontal chest radiograph. The lung fields are clear, no obstruction lesion or cavitating lesion or cavitating lesion, but they are bilateral enlarged hilar lymphadenopathy. So this is a case of pulmonary TB. Hilar lymphadenopathy in case of pulmonary TB patient. Okay, case number 15. Okay, frontal chest radiograph with the heart size is prominent. Okay, it's enlarged cardiac silhouette. We can see the right descending pulmonary artery are enlarged here. Okay, so this is a case of pulmonary hypertension. You can see the enlarged pulmonary arteries. Okay, frontal chest radiograph. You can see the heart size is enlarged. The mediastinal is widened. Okay, we can see here the aortic arch and descending thoracic artery, thoracic aorta is enlarged. So this is a case of thoracic aortic aneurysm. Okay, the enlarged aortic arch and descending thoracic artery pushing the trachea to the opposite side, to the right side. Otherwise, the lung fields are clear. Okay, sum up the 4 review or hidden areas. The first one is lung abscess. Second one, hilar region. Third one, the retrocardiac region. And lastly, the retrodiaphragmatic area. Okay, we need to review all this area. Not only we have to see the both bilateral lung field, but we need to scrutinize all these areas, especially not only in exam lah. In every single day, every time we see a patient, we see a chest radiograph of belong to patient, we need to see all these review areas. Okay, that's all for my sharing today. For the take home message, okay, you have to know your case very well, know the history, know the clinical finding, and then after you know the history and clinical finding, and then you look at the imaging, then you will have a better differential diagnosis and better diagnosis. So this will help you in managing the patient. Okay, if you only see the chest radiograph without knowing the history, without knowing the clinical findings, it will be very difficult to come out with a certain diagnosis. Okay, so that's one of the reason your colleague from radiology department always ask the clinical finding or clinical history. Okay, we need to be systematic in reviewing a chest radiograph. Okay, we need to assess the quality itself. Okay, in any suboptimal findings, any suboptimal studies or image, so there will be expected limitation. So we don't expect much from a suboptimal study. So that's why for us in radiology, the quality or the quality of a certain study is very important, because if the study is suboptimal, we couldn't assess that area in the chest radiograph, especially in the chest. We couldn't assess it properly. We might go to the false positive. We might find any false negative. So it's very difficult. It's a suboptimal study, so we need to assess it properly. And then for the approach, okay, as I said previously, A, B, C, D, E, A for airway, B, breathing, C, cardiac, D, diaphragm, E, extrathoracic structures, F, lung fields, G, great vessel, and H for hila and sternum. Okay, the last one, practice, practice, and practice. When you look at the normal radiograph, don't ignore it, just remember it properly, because when you remember a normal chest radiograph, so it will be easier for you to pick up any abnormality in any abnormal radiograph. So make it a habit. So every single radiograph you look at every single radiograph, so it is a learning point. It is a learning process. Every time you see a chest radiograph, even it is a normal one, okay, because the more you see the normal chest radiograph, okay, the easier you will pick up the abnormality, okay, because you know if there is abnormal, you already know that, oh, this is not normal finding there, so you know it is not normal. So the normal chest radiograph is also important, okay, obviously the practice. So that's why you need to practice, practice, and practice. Okay, this is my reference. Okay, that's all for me. Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh.